The definitive report in this series of reports that we have made to you on the Comprehensive Clinical Evaluation Program looking at Persian Gulf illnesses. Some of you will remember we made a report on our first 1,000, then our first 2,000, then our first 10,000 patients. And now we're almost at 19,000 patients fully worked up in a very sophisticated clinical round of physical and laboratory and subspecialist examinations. These are almost all the people who have registered for this program and asked for an examination. So in terms of where we are with the population that's come forward and asked to be worked up medically, in terms of what we think we can speak firmly about as to what we have found, and in terms of the relationships between all the elements in the exam, we think we're about ready to give you not a final answer, but a rather definitive statement. I do want to make clear, I'm choosing that word, not a final answer, very carefully, because part of our commitment here is to not close the door, to not close the books. We will continue to follow this issue with the clinical program and with our ongoing research, declassification, investigational efforts, as long as there are any more stones or pebbles to turn over. So I would hope that you would not report this as a final or as a closeout statement. It is far from that. But we do believe, and you'll see when you pick up the report that we're issuing today, there are copies here for you, that we feel that from what you can learn from this sort of clinical examination, we have pretty well mined it. You remember that we initiated the program in the middle of 1994. Is my lavalier on? Can you hear me if I step back? You hear me all right? And we went through this series of reports. We have, as you'll see in the report, about 27,000 people who came in primarily through the hotline that we set up in California. About 21,000 of those asked for the clinical exam that we had developed, coordinated with the VA. And this report that you're getting now is the information on almost 19,000 of those patients. I have the next. You might as well stay up there, Gary. I'm going to go fairly quickly through this so that everybody can get to file. In the report, these are the key findings of that report. As I said on the other times that I've been up here talking about it, this population is characterized by a quite broad range of diagnoses that go all across the medical spectrum, all organ systems, all kinds of diagnoses, and most important for where we came from in this issue, there is no indication that we can find of clustering. There is not a single organ system, kind of illness that we would associate with a specific cause that clusters in this very large group. It's probably the largest group of people ever studied in this kind of an endeavor. Of the patients who've come in to the CCEP, Comprehensive Clinical Evaluation Program, severe disability is not a common feature. Now here I also want to add a note of caution. Of course, we are dealing with patients in this investigation who are still on active duty or who are dependents of those on active duty. And it is not impossible that those who have greater disability may well have left the military in the time since the desert. But of those who are in the system, disability measured by lost work days is not a major factor. This is a commercial. I think our doctors and nurses who've done this thing out in our med centers have done an extraordinary job, and our patients agree. Most important, we have found no indication, as others before us have found no indication, and certainly in this very large investigation, no indication of a unique illness or a Persian Gulf syndrome or a single entity that would account for illness in any large or significant fraction of these 20,000 people. Let's do the next one. My lavalier is dead. Well, they promised me it was going to be on. And I noticed Admiral Smith had trouble with it when he left, so I'll try to stay here. Shout if I get out of range. These are the most prevalent symptoms among about the first 18,000 of those 19,000 patients. These are upside down the way I view the world, so read from the bottom up. The four most common symptoms, joint pain, fatigue, headache, and memory loss, again, are the very ones that were the complaints that first came to attention as this became a public concern 3 years or so ago. Next one. And of the diagnoses of these patients, this is a cutout of those. I want to, if you take the top three, musculoskeletal conditions, psychological conditions, and this area here called signs, symptoms, and ill-defined conditions, they represent well over half of all the diagnoses among those patients. I want to say a word about signs, symptoms, and ill-defined conditions. Sometimes that label is misinterpreted and read as we don't know what's going on with those people. That's not at all the case. In the formal system of disease classification that the medical profession uses, this is a sort of a large grab bag of things that may be an abnormal laboratory test that can't be tied to a specific diagnosis, or a common symptom that isn't backed up by a detailed diagnosis. You may know, those of you who have kids, that very common in pediatric practice is abdominal pain without any other diagnosis attached to it. Abdominal pain of unknown etiology after all the expected diagnoses that would be associated or ruled out. Well, that would fall in this kind of group. Again, I put it up to show you the variety of diagnostic categories and the big three. We had, right from the start, we asked the Institute of Medicine, which is the medical arm of the National Academy of Sciences, to put together a committee that would act as a sounding board for us, as an expert group that could look and measure the quality of our work and give us constructive criticism about the directions that we are going in. And they put out a final report of their effort several months ago. I just want to give you 4 quotes from that report to back up against the things that I have said. First, they felt that we had done our work well. Second, the IOM committee encourages the DoD to emphasize in its future reports that psychosocial stressors can produce physical and psychological effects that are as real and potentially devastating as physical, chemical, or biological stressors, end quote. I put that up here because each time I've come up, I've tried to emphasize to you that because we are saying there is no syndrome, because we are saying there is no unique illness, because our data show that the largest single category of diagnoses are psychological ones, it is terribly important for us to understand and to stress that this is not saying that these symptoms and that these diagnoses are not real, or that all this is in our vets' heads or some such. This is as real, as relevant, and as important to the health of our people and our responsibilities for that as a bad hip from falling off the back of a Humvee. Next one. The IOM committee agreed, as I have said, that we don't find any clinical evidence in this really exhaustive clinical study for an unknown serious illness among Persian Gulf veterans. But they make the point, and I'd like to leave that point with you, that there well may be small groups, small numbers of patients with illnesses that we have not precisely targeted yet or targeted at all yet. We don't find them, and we do know that they don't represent any large proportion, any significant proportion of Persian Gulf illnesses among desert veterans. But we can't say at this moment that there might not be twosies and threesies and small numbers of clusters of people who were exposed to some particular issue. The best example here, of course, is the parasitic disease leishmaniasis, which had great favor in the press as, quote, the cause of Persian Gulf illness some 3.5 years ago. We know we've diagnosed, I believe it's 32, isn't it, Colonel Patterson? 32 cases of leishmaniasis among the 697,000 returned veterans. There may be other small numbers of things buried in these 19,000 examinations that we have not yet found, and that's an important point. That's another reason to keep looking.
That's not 18%. That's small. That's less than 18%.
18. Oh, we're now talking. I think what the IOM had in mind, and what I'm certainly trying to say, we're talking way down in fractions of a fraction of a percent. Were there 15 members of a motor pool, for example, who on a given day were exposed to a spill from some chemical or fuel that they were working with, and who became ill? We might not see that, is what the IOM is saying, because the numbers are so small. But that's a counterpoint to the issue that there is no single, unique, large majority illness or syndrome in here. Next. Well, where do we go from here? We will continue to take care of our people in this clinical effort as it progresses, and we will use this model, by the way, for future deployments and return from future deployments. But we have other initiatives that will be ongoing as well. We have $12 million in Persian Gulf illness research, both for FY95 and for FY96. And really, that's where we need to move now. The clinical examination effort is a rather crude tool. There are a lot of things that will help you learn, the directional signposts it will give you, as I've just mentioned. But you can't be precise about etiology or a lot of other things. And it's now in the area of research on epidemiologic research, biochemical research, et cetera, that we need to press forward in. We have, as many of you know, an incident investigation team, which has another hotline and which responds to for follow-up and investigation calls or assertions or questions about possible events or causes of illness. I must tell you that the most important findings of the investigation team to date, and they have run down everything that they've been given, ought to be published in the Journal of Negative Results. The most important result of the investigation team so far is that there is no pattern. There are not events that have checked out. Again, no reason to stop looking and close the book, but the evidence begins to be very strong. And finally, we're proceeding as the department committed to last year with an effort to declassify documents, put many of them on the internet, and make all the relevant information out of the desert available to the general public. I should also add that one of the things that we are going to do with the clinical information, all the database that lies behind this is an enormous clinical database, and we will, I believe, in June of this year, make that database public to non-federal investigators who wish to use it for their own research purposes, looking at possible correlations, et cetera. We're also heavily engaged now in cluster analysis, computer runs looking to see if anything is related to anything else in terms of statistical probabilities. I believe the computers looked at, is it 100,000 or 47,000, some very large number of thousand possible correlations of anything with anything else. All of them have turned up negative so far. I believe the possible number of correlations that anyone can get out of here is around 16 million, so the computer has a ways to spin. But again, the weight of the evidence is beginning to push very, very heavily in the direction that I have described. I think there may be one more. Two more. We'll do them quickly. This is just some more on future directions. It starts again with where we started this. We started it figuring that the way you begin dealing with a clinical problem is you look at the patients you're responsible for, and I think that has proved very valuable for us. And we will go on. One of the useful things that has come out of this has been a major change in the way we prepare for deployments in preventive medicine sense. the things that we do during deployment, both looking for potential causes of problems, and the things that we will be doing after deployment for health assessments as the troops come back. And one more, Gary, I think. Well, these basically just outline what I have said. Let me make one comment about this last one. Some of you heard me say before that a most valuable tool, which is just about now online, has been a computer modeling technique put together by the Army, which makes it possible to locate any unit, any given day, as to their geographic position in the Gulf. And we can now take all this clinical data, and we can say, well, is there any correlation of people with red hair in terms of where they were on a particular day in the Gulf and the symptoms that they may have described to the CCEP. Again, that's work that will be ongoing and may yield us some increased insight into the problem. I'll stop with that. Yeah.
Doctor, do you know of any epidemiological study involving examinations of people in a systematic way that is this large anywhere?
Not of this kind. I hesitate to say this is the biggest, because there's always somebody that's going to say that they have one that's larger. I think in this context of trying to look retrospectively at an issue that's been raised of a mystery illness or new syndrome or a emergent disease or that category, I'm not aware of any, and I would imagine that there is not. I mean, the nature of this, I think, is what has made it both necessary and possible to examine a very large number of people.
The largest of its kind by the DoD?
I'm certain that that's true.
And lastly, you mentioned, am I correct, that $12 million was the budget in 2 successive years, so the total cost of this study was $24 million?
That's our research area. We did this clinical program, our people did out of Hyde. I mean, the doctors and nurses at Walter Reed or at Wilfred Hall or any of our med centers, they saw those patients according to protocol, and that just came out of the regular health budget. The best quick and dirty that we have done on total costs of this for 95, 96, including the declassification, the investigation team, the research effort, and the clinical comprehensive program, is somewhere in the $80 million range. I used to say $100 million. I guess I was a little high, but that's the cost. But much of it is absorbed by ongoing budget efforts.
Aside from the evidence of
no
Gulf War disease syndrome, does anything unique jump out? Is it unique for to have so many joint pains, headaches, the 4 biggest ones you described? Is that unique for this group? Is there anything unique about this Gulf War group?
I think what I would say the lesson in this is that when you send a large number of healthy young people off into an extremely dangerous and stressful environment, surprise, surprise, some proportion of them come home with a variety of illnesses. Some of those illnesses are the direct result of physical events that have occurred. Again, the person who falls off the Humvee and has a chronically bad knee. Some of them are results of all the stressors, all the psychological and individual stresses that took place to people in this austere environment with the threats hanging over them and all the rest of that. Some of them are diseases that would have developed anyway, whether they had gone to the Gulf or whether they had stayed in San Diego. And what you get is a complex mosaic. I mean, the bottom line here is a complex mosaic of diseases and conditions that are in part a reflection of this population. And you'll see in the report we make some crude comparison with other population-based studies that have been done. There aren't many of them. And some of them are a result of the particular environment that people found themselves in. What is not apparent in this study, after some very careful looking, is some, again, unique, mysterious, overriding cause that would explain a large volume or any significant fraction of these symptoms and illnesses.
Dr. Joseph, the 18%, put that into perspective. Is that a large number, general population of people that would show these ill-defined symptoms, or is that on average, or how would you put that in perspective?
In the other population-based studies that have been done, and I have to be clear that you can't draw exact comparison. There are no other apples to compare with these apples because the various national health surveys and primary care studies have been done. The population be a different age or a gender mix or why they came in for the study or who they are, et cetera. But given that we're comparing apples and oranges and pears, but all the same kind of thing, this is not an unusual. In some studies like this, up to 75% of conditions will not be directly pinned down to a specific diagnosis, and probably. The physician's intuitive response to that question would be somewhere around a quarter of your patients you never establish a firm diagnosis on. Think to yourselves of the last 10 times you've gone to see the physician or your family's gone to a physician, and how many times in that 10 times you come home saying, oh yes, this is mycoplasma pneumonia, or even, oh yes, this is pneumonia. Medicine doesn't really work that way. This is not a surprising figure in there.
Dr. Joseph, how frustrating is it to be at this point, to have come so far, to have spent so much time and money, and still not have an indication of what kind of illness is involved?
Well, I think you missed the point. It's not frustrating at all. I think, number one, our people have done an extraordinary job taking care of our patients. Number two, what we have shown is the very important finding that there is no focused, specific, unique illness. That's not frustrating. What's frustrating is the difficulty of communicating that sometimes, as your question indicates. I think we have a very important answer here. It may not be the answer that someone who wants to, kind of whip up the mystery disease would like to hear, but it is the answer you get when you look with very high scientific quality at 20,000 patients. Not at all frustrating.
Thank you for the answer. That's what I needed.
Yeah, given the chemical soup environmentally, both in the atmosphere that the troops were exposed to in the Gulf, basically two questions. Medically, is this kind of a new sort of unique thing that will, one, prevent you from ever finding a specific cause because there were so many things involved, and is this the kind of thing we have to start looking at from now on in combat? Industrial chemicals,
I suspect. Well, first of all, I think the data clearly show, and I would personally feel very secure in saying that this environmental or chemical soup you described is responsible for only a minuscule sub-percentage fraction of the symptoms and diagnoses we see. And we've got some data that show that, the Army smoke plume study, et cetera. But I guess I would say that another important thing about this, I think if this had been done before, if circumstances had called for it to be done before, after former conflicts, my guess is somebody would have been up here in the 1940s or the early 1970s and describing about the same thing. I think if you look at a population of healthy young people who go off to war in a very hostile environment, which it always is, you would see something like this. Perhaps that's one of the most important findings. So rather than kind of anticipating that after each successive deployment or contingency we will see a mystery Bosnian illness or a mystery Antarctic illness or something, I think the lesson we'll take out of it, and this is the lesson that we are implementing in Joint Endeavor, is that it pays good dividends both in terms of the medical care that you give your patients and also in understanding what's happening during and after deployment to really look ahead preventively. We have in Bosnia a very heavy emphasis on preventive medicine teams on the ground, combat stress teams on the ground, environmental and epidemiological laboratories for good, accurate disease surveillance on the ground, pre-deployment health assessment of people going over, and a plan for post-deployment health assessment of people coming back. So if and as questions develop on the current deployment or future deployments, we'll be in a better position to get data quickly, both to either understand a general pattern such as this or under the possibility, certainly there is a possibility that you might be in a situation where there is a specific trigger or a unique illness. We'll be better positioned to find it. Yeah.
Secretary, were you saying that a small number of troops were or may have been exposed to chemical or biological weapon agents?
I was most definitively not saying that. We really have no persuasive evidence from any of the vectors that have looked at this, starting with the Defense Science Board, our own work, the investigative team, the clinical pattern among this 20,000 people that we've looked at. There is absolutely no persuasive evidence that chemical or biological weapons are associated with this. I also keep saying we're not closing the book. We're going to continue to look. When somebody calls up and says, I know I was at Al Jabail on X and XY date, and I know I was gassed, etc., we're going to continue to run that issue down. We're continuing to declassify the documents, and we're continuing to match that data with the clinical data. So far, we come up with nothing that would give any credence to those suppositions.
About the future. So I was wondering, one of the things that's been an issue is a few people talk about vaccines, cocktails of medicines that they suspect have given them problems. Now the FDA are planning to make permanent a ruling to waive the informed consent for experimental drugs for the future. Is that a good way, do you think, to encourage confidence in the system?
Well, I think your statement's a little overdrawn about the FDA planning to waive informed consent. I mean, the FDA is looking at the interim rule status that deals with military contingencies, and that's a complicated issue. I would be very surprised if the FDA would take off I can't speak for the FDA, but if the FDA would take off all the protective things that we put around vaccines and other medicines, et cetera, that are given to troops on deployment. I think that whether this is confidence building or not depends on the objectivity with which people look at the issue. You know, if you look at the data and you look at how it all fits together, whether it's on the chem-bio warfare agents issue or whether it's on the smoke plume issue or whatever, the data, while not absolutely airtight, because this is not a carefully designed prospective experiment, but all the data we have moves in one direction. There really is not a single thing in any of these patterns, whether it's on the research side, whether it's on declass document side, certainly whether it's in our clinical experience side, that is an outlier that moves in the other direction. So at some point, I mean, that's really the way medicine works. At some point you say there's enough information all moving in the same direction without conspicuous outlying offshoots that go in an opposite direction, that it becomes reasonable to stand pretty firm on your conclusions. One more. Yeah, either one. Whoever can talk first.
Okay.
We'll do one more. Go ahead.
Is any data available from other coalition forces relative to the medical issue they faced?
Well, as you may know, there has been considerable controversy, as there was and is here in the United States, in Britain. They have begun to do some research and done some clinical investigations, but nothing really on this scale. With that exception, there really is very little in the way of either reports from the armed forces, reports from veterans groups, et cetera, either from the North Atlantic Coalition partners or from the Middle Eastern Coalition partners that would indicate any issues of of this type, and specifically anything related to a unique syndrome. Last one.
Regardless of whether or not there's a unique overriding cause, I mean, do you believe that most of these veterans have got sick because of their service in the Gulf?
Well, in my business, the word "because" is a very important word. You know, if let's take my example way over here that I use about the guy that fell off the Humvee and now has a bad joint. Is that because of his? Absolutely. If we go over here in the middle and we talk about the person who has a chronic duodenal ulcer because either of the microorganism that causes ulcers we learned the last couple of years, or all my years of education in medicine, the psychic stresses that were on that person, is that because of the service in the Gulf. If we look at the person out here who develops rheumatoid arthritis, or you pick it, 10 years after or 5 years after they were in the Gulf, do we really know whether they would have developed it anyway, or whether it came on earlier, or is more severe, or developed it because of the whatever it is that causes rheumatoid arthritis? We don't know that either. So if you're asking me the question, are these symptoms and illnesses related in important ways to what happened to people because they deployed to the Gulf, I would say yes. But if you're asking me the question is, was there a specific etiologic agent, whether it was biological weaponry or moon dust or a new infectious organism that was there that got 19,000 people sick who wouldn't have gotten sick if they weren't there, I think the data show you emphatically not. Thank you.